It's time now for your local hospital on the town. Brought to you by Sierra Nevada Memorial Hospital, Dignity Health. And now here's your host, Dr. Brian Evans.
Welcome to On the Town in our hospital. I'm Dr. Brian Evans. I'm the president and CEO of Sierra Nevada Memorial Hospital. And today we have a great show for you. We're joined by one of my favorite guests, Dr. Rob Crockett, who is the president of the radiology group here at the hospital. Thanks for joining us, Dr. Crockett.
Thanks. I'm glad to be here.
Yeah. You know, we've got some time to talk about radiology and what radiology is, what you do as a radiologist, and kind of try to demystify some of that for folks that are listening. So I want to get right into it. So first of all, tell me, what is a radiologist? What kind of doctor is that?
Radiologists are specialists in medicine. So people come in to see their primary care doctor, and they refer patients to us. And we take a look inside their bodies. Mm-hmm. My job is to interpret the images that are taken of a person's insides.
Okay.
So we're kind of the man behind the curtain. Many people don't really see us because of that. In the past, it was just that. People would come in, they'd get an X-ray, CT scan, MRI. We would interpret it, provide a report back to the physician, or call them or talk to them, talk to the surgeon. And we may not have any contact with the patient. Nowadays, though, radiologists are involved more and more in micro-invasive or minimally invasive procedures. Mm-hmm. So my job frequently is to talk to a patient, introduce myself, get to know them, and then stick them with a large biopsy needle or put a catheter in them to do various things. We biopsy tumors, we drain abscesses, we sample various things, we drain the kidneys, we do a lot of things besides just interpret x-rays these days.
Okay, so things have really shifted from the sort of classic idea of a radiologist being in a dark room, the lights are all off, you're staring at a screen, staring at x-ray films all day long, and really never talking to a patient or putting hands on a patient, to now there's sort of more interaction and a lot of procedures.
Yeah, exactly. Now, we still spend a lot of time in a dark room for various reasons, but we look at computer screens now and not the old X-ray film, but it's still, you can see a little bit more if the room is the lighting is subdued. We have a little mood lighting in our rooms. We end up getting out of our rooms and seeing people, talking to people, and laying hands on procedures quite a bit now. Probably 50% or so of what I do is actually procedures now.
Wow. And the technology that supports all of this kind of activity has really changed over the years, hasn't it? I mean, back when I went to medical school a million years ago, we really relied more on the physical examination and plain x-rays.
Yeah.
And nowadays, there's some other modalities out there, correct?
Yeah, we notice once in a while that sometimes we're the physical examination performed by some doctors. I wouldn't want to say the ER specifically, but...
No, wouldn't say that.
But yeah, we end up looking inside to see what's going on. A patient might come into the emergency room, for example, with abdominal pain.
Yeah.
There's a lot of things in the abdomen, more than an average person might realize. Liver, spleen, kidneys, abdominal aorta, the bowel, various parts of the bowel, the stomach, the small bowel, the large bowel, in gals, the ovaries and uterus and so forth. So when there's abdominal pain, there's a lot of structures to look at, and physical examination can only take you so far with that. You look at all the factors like you do in the ER or anywhere else. You look at the laboratory values, examination, what the patient's telling you, their history. But ultimately, we end up doing often like a CT scan, for example, to look through all those organs and see what's going on. When we look on CT, the diagnosis often is like a slap in the face. I mean, you see that appendix, it's dilated, it's inflamed, it's swollen. There's a stone in there. You're like, okay, this is appendicitis, no question about it. Yeah. And you don't have to wonder anymore. You don't have to take the patient to the operating room, open them up to find out that it wasn't, in fact, the appendix. It was an ovarian cyst or something like that.
So that's a huge change, really, when you think about it, because in the older days, somebody could have abdominal pain, and really the only way to know for sure what was going on is to open the patient up physically, take a look inside, and surgeons used to do that all the time. But now the CT scanners have gotten better and better over the years too, right? They used to be
faster, primarily. I mean, it's the same idea. X-rays pass through, the thing rotates around. It's called computed tomography for a reason. They take the data out of the CT scanner, they put it through these array processors. It's a very specialized computer that takes the data and makes it into images. And then those images are like slices through the body, not just in one plane, but in sagittal and coronal. And we use some contrast frequently, intravenous contrast, to make the differentiation of the tissues even better. So we can see processes better. But yeah, it's the CT scanners have just in themselves, the physics of it is similar to what it used to be, but the technology is advanced, so it's much faster now.
You mentioned contrast, and I think some patients probably don't understand what the value is of the contrast. They get an IV placed typically, and then right before the scan, oftentimes they'll be given some of the contrast material. And where's that stuff going?
Yeah, so there's a lot of physics involved in radiology, and that's kind of the reason I got into radiology in the first place. I mean, I was going through college on an engineering track. I took physics, mathematics, calculus, vector analysis, all this stuff. And then got into biological sciences and went around kind of the backside to get into radiology. But when you talk about how we do radiology exams, you can have a kind of a superficial understanding that you inject this stuff into the veins and it makes things better. It makes it easier to see what's going on. The reason it works better is that we injected a compound that has iodine in it, and X-rays that we use are of the specific energy that are absorbed by iodine molecules. So the more iodine there is, the more dense whatever the thing appears on X-rays, the brighter it looks on the images. And so areas that have abnormal blood supply, abnormal vessels leak the contrast into the adjacent tissues, so you have a brighter structure to look at, like in a tumor or inflammation. So it really, the contrast, the intravenous compound that we inject really lays out the contrast much better.
Right. So the patient can, they're sitting there, the x-rays go through their body, but when they hit the iodine, they don't. So you can, when you get an image later, the doctor can really determine what's going on more readily.
Not every case requires the iodine, extra iodine. I mean, if a person might have kidney stones are super bright on CT anyway. They're really dense, so we can see them easily. We don't need contrast.
Yeah, you can see a small one.
Very small, minimal size, like 1 millimeter.
And we've got a brand new CT scanner here at the hospital now. Are you guys excited about that in the radiology group?
Yep. We are.
Good.
It's, first of all, exciting to have the CT scanner not in the parking lot.
Yes.
We have to schlep people back and forth to the parking lot and ourselves because we do procedures out there too.
Right.
But now it's in a much nicer, much larger radiology suite where the CT scanner is. And the CT scanner itself is faster, has higher contrast, has a lower radiation dose, and also it has new features on it. One of the features that we haven't had here before is called CT fluoroscopy. Fluoroscopy is where in the days of old when the person would be, the X-ray source would be here, the fluoroscopy screen would here, the X-rays would go through the patient, you'd see in real time the patient's body moving, behind the screen.
Sure.
So you could look at what was happening in real time. You could see how their joints were working and their bowels were moving and things like that. Well, on CT scan, usually in the past you would scan and then you would scan, look to see when you're passing a needle into like a tumor, you would have to intermittently look to see where you put the needle.
Make sure you're going in the right spot.
Exactly.
Awesome.
So using CT fluoroscopy now, you can watch as the needle advances into the tumor directly. And you can see, you wouldn't think that'd be important, but people are, of course, living, hopefully.
Yeah.
And we're imaging live patients that are breathing, moving, pulsating, and so forth.
So this is safer, this is better, it's more accurate. That's awesome. So
much better.
I'm joined today by Dr. Rob Crockett. He's the president of the radiology group here at Sierra Nevada Memorial Hospital. We're going to talk about more technology and why you went into radiology here after the break.
Okay, thanks.
Welcome back to On the Town at Sierra Nevada Memorial Hospital. I'm Dr. Brian Evans, President and CEO of the hospital here, and I'm joined by Dr. Rob Crockett, who is the President of the Radiology Group. Thanks for joining us, Rob.
Absolutely.
Rob, we were talking about CT scanners. A lot of people call those CAT scanners. We've got PET scanners. What's with the CAT and the PET? I mean, is it for cats and pets, or are we talking about when are we going to image patients that are human beings? For crying out loud, what's the
There are some acronyms. It's not NASA we're talking about. Well, they love acronyms, but CAT scanner, CT stands for computed tomography. CAT is computed axial tomography, which is kind of an outdated thing because we use not only axial but coronal and sagittal. And
talking about the way that we create the images, like what sort of slice of the body we're looking at.
Right. Yeah. CT scanner simply means that we use X-rays, but it's kind of the X-ray tube actually sends out a beam like a fan. The person is lying here like this. The fan goes like this. It rotates around the patient.
Yeah.
And if you're in the scanner, you can feel something happening, rotating around. And so it's rotating around, but at the same time, there's a set of detectors on the other side that's detecting each of those little radiants from the fan. So it rotates around, and then the person goes through it at the same time. So it's a complicated set of data.
Yeah.
They run it through this set of fancy algorithms from mathematics called the Fourier transform to make waves into pixels, basically.
Yeah.
And then you get an image out the other side. But it's X-rays passing through. We use other modalities to create cross-sectional images. We use ultrasound as well, sound waves, high-frequency sound, usually like 3 megahertz or so sound waves. Pretty high. I mean, that's pretty high for a sound wave. It's well above what you can hear. And then we also use magnetic resonance, where you kind of tap a person's protons, really, proton imaging is what magnetic resonance imaging is. You tap their protons in their fat and their water, and those little protons go ding and make a little sound in the radio frequency band, and you listen for that.
Not that we could hear.
Not that you could hear. It's up there in frequency, again, well above what you could hear.
Yeah.
And then you take that same data and you run it through these similar algorithms, and you generate cross-sectional images again.
It really is, at a point now where it's almost like Star Trek. We've got all these devices, and in the last year, there's been a huge change at this hospital in terms of the technology that we now have. New CT scanner just went live. We're getting a brand new MRI. We've had an MRI for a long time, of course, but a new MRI is coming, and also several new ultrasound devices. What else is new? We have a new nuke med camera as well, right?
Yeah, we started to talk about PET scans a little bit, but CT is now added to nuclear medicine images. Nuclear medicine images, we inject stuff into the veins, but it's a chemical that's taken up by the body. It's a physiologic chemical, that can be taken up in the bones, can be taken up by tumors, can be taken up by other things, the liver, and excreted in the bile ducts. And the nuclear medicine camera looks for the emitted minimal radiation that's coming out of the radioactive materials that we inject.
So this is more of a way to tell how the body is functioning as opposed to just how it looks.
Exactly. It's a physiologic study rather than a morphologic study, how it works rather than how it looks. If you think about pathology, you could actually slice through a cadaver and look at the cross-section of it. That's kind of what CT, MRI, not so much MRI, but ultrasound looks like. I mean, it's kind of like it's an anatomic image. Whereas nuclear medicine is a physiologic image. You're looking at how these chemicals are distributed through the body.
Sure.
Yeah. So
all this technology, it's sort of easy, I think, for patients to get lost in the technology of all this and wonder what's going on and what all of this means. How do you interact with the patients, and how does your team in the radiology department handle the patients that are coming through the hospital and explain to them what's going on so that they're not nervous about it and afraid of it?
We have a huge team of people that's involved in just that. Their first line is the schedulers. They accept the request for an examination from a physician's office typically. And they are pretty good at looking at the request that's asked of them and interpreting that to make sure that what's requested matches the reason that the exam is being done. Like we talked about, like a person might come in for a screening mammogram, and they don't have any problems. They just want to make sure they don't have breast cancer. Do it every year, every other year.
Yep.
So, but if a person comes in and says, I've got this thing I'm feeling here.
Yep.
We're like, okay, that's not a screening examination. If they have an issue, we're going to have a more targeted examination looking specifically at that area. So that would be a diagnostic mammogram rather than a screening mammogram. A subtle difference, really, but a pretty dramatic difference in how it's actually executed.
Two different approaches to that situation.
Right.
Okay. And why did you choose to go into this particular specialty of medicine as opposed to the many? I mean, there's over 100 different specialties of medicine nowadays.
Right.
Why was it radiology and interventional radiology that drew you in?
Yeah. My dad is a doctor. He's an anesthesiologist. And growing up as a kid of a doctor, I was determined not to be a doctor. Absolutely not going to do that, not going there. I got halfway through college in engineering. Always had an interest in electronics, kind of physics, even astronomy, kind of that end of the science spectrum.
Yeah.
Got into stereo imaging for a while when I was a kid. Stereo imaging, 2 images, just like your eyes. You look 2 separate images at each eye. You can see the depth of it. Anyway, the old time stereoscopes you look through, of the scenery. You can see 3 dimensions. So I started seeing some of that in radiology, and that kind of hooked me into radiology when I was early on in the process. But having gone in college to having an engineering background, the first 2 years I was all engineering, and then kind of saw the light, like, okay, this is not exactly what I'm looking for in life. I switched to a right-hand turn or left-hand turn, depending on your perspective, into biological sciences, and then end up just kind of falling into medicine as this natural progression for me. I don't know how to explain it exactly. It just seemed like the path of least resistance. I got into medicine, started medical school, and then the physics kind of was in my background. So radiology is pretty heavily involved with physics and engineering as the imaging part of it. The interpretive part of it, you don't have to be a physicist to be a radiologist. Most radiologists are not. But for me, going through the training process, the physics, knowing the physics made it a lot easier for me to understand exactly what we're doing, how we're doing it, and how to best use radiology.
Well, it's certainly one of the most highly technical specialties in medicine. We are very lucky to have you with your background here at Sierra Nevada. We're going to take a short break, and when we come back, I want to talk a little bit about the breast imaging program at Sierra Nevada, talk a little bit about veins and what we can do for veins here as well, and we'll be back in just a moment. Welcome back to On the Town at Sierra Nevada Memorial Hospital. I'm joined today by Dr. Rob Crockett. Thanks for being here, Dr. Crockett.
Happy to be here.
We're talking about radiology. We're talking about what radiology is, what a radiologist is, and we've kind of covered the different modalities, the different types of technology that we use at the hospital. Tons of technology that we brought here, which is actually amazing for a smaller community hospital in an area like Grass Valley. We really have all the different equipment that even large hospitals in urban centers have, which is nice. Tell me, why did you choose to practice medicine and practice radiology here in a community like Nevada County?
Well, I grew up in Shasta County on a ranch, actually. Cattle, chicken, sheep, the whole bit. I moved irrigation pipes when I was a teenager back and forth across the field. So I kind of grew up in a really small town. When you drive into the town I grew up in, it was Millville. When you cross the bridge into town, I can't remember if the elevation was 500 or the population was 500. It's one or the other. I think it's 50 both. And 500. Yeah. So I kind of like small towns, and I was looking for a place I have 3 kids, and at the time they were small, and a place that has great schools and great place to live, and a great medical community as well. Having gone through training, you go all around the United States. I actually went to Texas and Pittsburgh, Pennsylvania, and Seattle, and then I worked for a little while in Eureka. So I really did a circuit trying to get back to this area where I kind of grew up and where my wife grew up. So I was looking for a friendly community. I was looking for a medical community that was highly skilled, yet had insight enough to know when they're over their head, and had availability of some specialty things that we could refer to so that people here wouldn't feel they needed to take on things they weren't comfortable with. So Grass Valley really fits a lot of those criteria. And I didn't, at the time, I didn't really think about directly what those criteria were, but in retrospect, those were the things I was looking for. So the nice thing about the community here is we have people here that want to be here, that love to be here, love to see patients, love to work together as a team. And if they feel like, this is something that, the nice thing about a community hospital is you do a lot of the really common things and you get really good at those things. If you find something that's unusual or odd and it doesn't quite fit into the patterns that you're, as a physician, you're comfortable with and you need some help on that, we have a lot of resources immediately available in, Roseville or Sacramento or San Francisco or Palo Alto, Stanford. So we end up working with a lot of people close by that have very specialized skills as well. So overall, the patient gets the best care possible.
Right.
Because we're really good at the common things, and we're really good at saying, and we're really willing to say, hey, we need some help with this. It works out perfectly.
So we have a lot of folks in the community that are retired people move to Western Nevada County in order to retire. A lot of them coming from the Bay Area and other places, and they certainly look around at what's available as far as medical services. And as we've been talking, radiology services and technology is a big part of that. What would you tell folks that are wondering what our level of technology is and what our overall resources are for a community like this one?
Yeah, the radiology equipment is a huge part of the radiology department. You wouldn't think that. You think that when you have a scanner, you're good. You don't have to worry about it. But the technology is still advancing so rapidly in radiology that the equipment is really obsolete in about 5 years. Which, we have millions of dollars of equipment down there. CT, MRI, ultrasound, nuclear medicine cameras. We even have a PET scanner that's coming.
Yep.
So it has to be updated constantly. And so we have this rolling program to try to keep the latest, greatest equipment so that we can do the finest quality we can do. And that's expensive.
Yes.
And that's tough to manage in a small community environment often, where budgetary constraints can really limit what you have available. But we're really fortunate here that we have the support of the community through the foundation. It is remarkable, the support in the community. I think it has to do with the fact that a lot of our community members are retirees. Roughly half of the people in this area are retirees. So they're available to participate in the foundation activities, and I love it too.
And they're motivated to do it.
Yeah, I have a lot of fun with the foundation. All the events they have.
Yep.
Starry Nights and Moulin Rouge are my favorite. But
and the golf tournament is coming up.
Yeah, absolutely.
Well, good. We did want to talk about breast imaging. That's something that we do quite a bit of here, and you have a robust program. What are the key elements of the breast imaging program here at Sierra Nevada?
We have top quality equipment. So we have a 3D tomographic mammography. So for screening mammography, we do the best we can possibly do with that. Those images are reviewed on our high-resolution monitors and on our specific workstations for that. And all of our radiologists are ACR certified in mammography.
Okay.
And we do a really fine job. So, and the patients, when we have an issue, if we find something on screening mammography, about 10% of gals end up having breast cancer at some point in their life. So very common. And we have a well-oiled machine to take care of that. So we bring the person back immediately within a day or two, typically, to get a further evaluation. Most of the time, it ends up being nothing, a benign mass, or it was the way the breast was imaged, or there was something. But sometimes, like maybe 30% of the time we bring people back, it ends up being maybe a breast cancer. And then we immediately can do a biopsy, and then we refer those people immediately to our local physicians, surgeons, oncologists, radiation therapists, and so forth, take care of things right away. So we have a really robust system for taking care of that. I mean, it's really a breast care system, and we're a key part of that in the screening of mammography.
Absolutely, because it involves a lot of other physicians, a lot of other professionals, surgeons, primary care doctors, cancer doctors, potentially. So, okay, and then there's also a lot of work in veins. So there's equipment and there's procedures that can be done as far as veins. Tell me about that service.
Yeah, about 7 years ago or so in radiology, we had, through a series of circumstances, we ended up having an extra radiologist. And so we were looking for a little extra business to help fill out our ranks with workload. So we looked into a couple different things. In radiology, our specialty is in imaging guided procedures, using imaging for various reasons to make diagnosis and guide procedures. And one part of the interventional component, interventional meaning we go in and do things as opposed to just looking, is vein work. And it turns out that vein problems are very common.
Yes.
People know them as varicose veins, where the blood is flowing back from the tissues, back from the legs, and there's valves in the veins. The valves are supposed to carry the blood only one direction. If the blood is actually going back down in the veins, causing higher pressure in the veins, it can actually inhibit blood coming out of the tissues to the point where the tissues become ischemic. They don't have enough oxygen to survive.
You got to get the blood moving in the right direction.
Right. So the tissues can start to break down if the veins aren't working right. So we're involved in, we developed a clinic here that we have 1 day a week where we see patients where it's thought that they may have a vein problem. We do a very exhaustive workup of that using ultrasound primarily, but also physical exam. And then we treat those veins. If they have abnormal greater saphenous, small saphenous, perforator veins, we look, we find, we destroy.
And then you can do all kinds of work to make things better.
Yeah, most of the time what we're doing is taking veins out of commission. Veins that are not operating correctly, we remove them.
Okay.
We always get the question that, you need those veins. How come you're removing them? How come you're making them go away?
Yeah.
But as opposed to arteries, where you have basically a single pathway all the way out to the tissues, veins, there's many pathways coming back.
There's more than one. Yeah, there's branches of a tree.
So if there's one that's bad, you can take that out of commission as long as you confirm the other ones are good before you do that. And so we use radiofrequency ablation through a catheter, a little tiny tube with a little coil in it, radiofrequency generator, to heat up the inside of the vessel and then compress that so that it's injured and then it heals closed because it's injured.
Yep.
Or we use sclerotherapy, injecting some surfactant into the vessels. It irritates the vein. It's a little bit of it's like soap. It looks just like soap. It's kind of a foamy material. Or now we've developed a new technique where we use glue. It's like crazy glue. It's very similar. It's kind of like Dermabond that they use in the ER to close up wounds.
Crazy glue in the veins.
Yeah.
Okay.
We put the glue in there. We hold the vein closed, and we just progressively pull the catheter back as we glue the vein closed all the way up. Person gets up, walks out. No compression stockings needed. One-stop shop.
That's a technology I had not anticipated would be coming. So thank you for
neither.
that.
And I love that. It's amazing technology. I love it. It really works well.
Well, good. Well, Dr. Crockett, I want to thank you for being here. It was a great discussion, and I appreciate you walking us through some of this very complex technology. And it's very, I think, gratifying to know that we have the equipment, we have the resources, and we have the expertise with you and the rest of your team here at Sierra Nevada Memorial Hospital to take care of this great community. So thank you for being here. This has been On the Town at Sierra Nevada Memorial Hospital. I'm Dr. Brian Evans, the President and CEO of Sierra Nevada. Thank you.
Thank you.
This has been your local hospital on the town, brought to you by Sierra Nevada Memorial Hospital Dignity Health. Listen to Fourth Monday of every month to learn more about your local hospital.